Good evening, everyone. I just want to welcome everyone to tonight's Journal Club meeting. My name is Mark Carrasco. It's my pleasure to serve as the club advisor, moderating tonight's Journal Club. I did my family medicine training at New Vance Health, and that's in upstate New York, and I'm currently the Chief Sports Fellow at UAB, the University of Alabama at Birmingham. After I graduate in a month and a half, I'll be going back to New Vance Health, which is now part of Northwell Health in Brookfield, Connecticut. And my clinical and research interests include adaptive sports, global health, and exercise medicine. The goal of the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from a list of the top 120 articles that every sports medicine fellow should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. We are featuring one presentation tonight. The format for the Journal Club meeting is that our featured presenter will have approximately a 20-minute block of time that is followed by a brief Q&A segment after his presentation. Please enter your questions using the chat function, and during the Q&A, I'll read each question and ask the presenter and their club mentor to respond. I'm pleased to introduce our featured presenter tonight, Matthew Labkovski, and his club mentor, Dr. Tammy Ng. Matthew is currently an MS2 at Nova Southeastern University, Karam Patel College of Osteopathic Medicine in Davie, Florida. Matthew's interest in sports medicine started while being a student assistant and player development coach at the University of Miami for the men's basketball team, including coaching 4 future NBA draft picks. Matthew hopes to do sports medicine fellowship after residency in either peds or family medicine and looks forward to serving a diverse range of athletes. His presentation is on the article Sports Participation by Physically and Cognitively Challenged Young Athletes. I'd also like to thank Dr. Tammy Ng for serving as his club mentor. Tammy was born and raised in San Francisco Bay Area. Growing up, she loved gymnastics, but did not start taking class until she was 15 years old. After realizing that she was still unable to do the splits, nearly 6 months into training, she retired from this endeavor, instead choosing to pursue medicine. She studied neurobiology, physiology, and behavior at UC Davis, then moved to Philadelphia to complete medical school at Drexel University College of Medicine. After discovering how fun and gratifying it can be to take care for children, she decided to become a pediatrician and returned to UC Davis for her peds residency. During a pediatric orthopedic surgery rotation at St. Christopher's Hospital for Children during the 4th year of medical school, she also discovered her love for MSK and sports medicine. She's thrilled to have matched at the University of Washington for her fellowship training. Tammy loves traveling with her husband, going to amusement parks, baking cookies, and eating all the great food that Seattle has to offer. After spending 3 years living in Sacramento during residency, she now lives she has a soft spot for the Kings and will shamelessly root for them over her actual hometown team, the Warriors. All right, Matt, I'll let you take control and you could start whenever you're ready.
Thank you very much. So as Dr. Carrasco had mentioned, tonight's presentation is on sports participation by physically and cognitively challenged young athletes by Patel and Gradenos. So in terms of this article, the learning objectives are both to describe the wide spectrum of physical and cognitive disabilities that can affect participation in sport, and to understand these common medical issues that are related to these disabilities in order to then allow our athletes to perform the best that they can. And underneath, you can see we have a variety of different disabilities ranging from mental to physical cognitive disabilities. Okay. And then the research question, what are common medical issues associated with sports participation in athletes with physical and cognitive disabilities? Just as a preview, we'll be touching on different things from spinal injuries to hearing and listening to hearing and seeing disabilities, as well as cognitive disabilities. Okay. So in terms of the methods of this article, most articles range on a scale on a level of 1 to 5 evidence, with level 1 being the most evidence available, being that they were either done through a meta-analysis or a systematic review, all the way down to 5, which are based off of case studies, surveys, anecdotes, and qualitative research. So this article discusses as a narrative review, which is considered level 5 evidence. You'll see a lot of expert opinions, case reports, and systemic studies included within this article that backs up this. The article is an update from the 2002 version. So they had a 2002 version. This current article is based off of the 2010 version. In addition, there are over 100 references within the article. Background. So currently in the United States, there are over 3 million youth athletes with disabilities in the United States. However, we do have a limited amount of research for these athletes with disabilities. The 3 million athletes also excludes recreational sports athletes. This is only actually organized activities. Sports can positively affect mental health. This statement was in the background of the paper, and it was based off of the Special Olympics Reach Report study, as well as Youth Sports More Than Strains and Sprains by Patel et al. Currently, as well as the background, this is also based off of a functional classification system, which are sports and associate dependent. As such, the classification of athletes as disabled does depend on who is actually classifying them as disabled. As well, the previous studies only really incorporated able-bodied athletes, and so we are not 100% sure what this impact could have on athletes with disabilities. Okay, so currently we have the PPE monograph. In addition, we have a statement provided by Patel et al. In this study. They currently state that there are no guidelines specifically designed for the PPE of athletes who have different types of disabilities. There is a note, however, because in the PPE monograph by the AAP, among other organizations, there is a chapter dedicated to athletes with disabilities, which is chapter 8. However, within the PPE monograph by the AAP, among other organizations, the 5th edition does state that the PPE is not evidence-based. There's a lack of outcome data to demonstrate the overall effectiveness. As such, in our goal of the PPE, which is to promote athletes' health and safety, we have to keep this in mind in order to individualize the PPE for the individual athlete. So, in terms of the PPE for an athlete with disabilities, the most important thing for them is the detailed history. The detailed history is considered the most important thing according to the narrative review, and as such, should be especially important for the physician to obtain in both a consequential as well as detailed manner. Also important is that the office setting should be a familiar physician for the patient. The continuity of care is important for patients, and it's especially important for patients and athletes with disabilities. As well, the physician does need to consider disability and function and what the athlete is able to do versus not able to do, which we'll discuss a little bit more, especially with athletes with Down syndrome, among other disabilities. And it's also important to have medication reconciliation for these athletes in multiple different ways. There's therapeutic medications as well as ergogenic medications, and as such, it's important for the physician to be mindful of what the athlete is actually taking. As well, different organizations allow and don't allow certain medications to be used, and as such, it's important for the physician to ascribe to the recommendations and guidelines of each individual organization so that the athlete can continue to be competitive in that organization. Okay. Oops. There we go. So, MSK injuries. So according to the article, there's a similar injury incidence compared to athletes without disabilities. The most common kind of disability, MSK injury, is actually acute soft tissue injuries, which with few fractures and dislocations. The article actually specifically potentiates that this is due to less contact, the potentiation for less contact in these types of activities that these athletes are engaging in. As well, Ferreira and Peterson have speculated that the athletes have approximately the same rate of injury as non-athletes. This was based mostly on Summer Olympic data. And however, there were no prospective studies to actually further the knowledge of injury trends in this program. So again, this leads to the same approximate rate of injuries. Ferrara et al. Estimated that it was about 32% of athletes report at least one time loss injury in the past 6 months. Again, this is based off of mostly Olympic summer data, and it should be taken with a grain of salt. Different associations, though, have provided different statistics in terms of what their most common injuries are in terms of MSK injuries. For example, the National Wheelchair Athletic Association estimates that 57% of injuries are shoulder, arm, and elbow injuries, which is important to take into account because of the type of athlete that you're dealing with. You're dealing with an athlete in terms of wheelchairs who have a lot of overhead movements, and as such, they're more likely to injure this. The United States Association for the Blind Athlete estimates that 53% of injuries are to the lower extremity, and the Junior National Wheelchair Games estimates that their most injuries occur to either minor skin injuries or hyperthermia. So this is important to consider in the athlete based off of their selected disability. So spinal cord neurogenic impairment injuries. So in terms of spinal cord and spinal cord injuries, there are different complications that can arise from this. The first one being thermoregulation. This can lead to either hypothermia or hyperthermia, and it's usually in lesions above T8. The other thing that can arise is something called autonomic dysreflexia, which is considered an ergogenic aid in terms of the athletes. And it's found in lesions above T6 mostly, with some self-limited loss of sympathetic inhibition. This is almost a natural type of boosting for an athlete due to increased catecholamines, which could potentially reduce race times. For example, an athlete may decide not to catheterize themselves prior to an event, which could then increase the catecholamines and as such improve their actual performance. This was actually banned by the International Paralympic Committee in 1994. So it's also important to educate our athletes, including those with disabilities, about this and to make sure that they don't do this because it is considered illegal in certain organizations. As well, myelomeningeal seals have an increased risk for limb strains and bladder and bowel control issues. So it's necessary to implement a catheterization regimen for these types of athletes, and to also be mindful of the mental side of the athletes. So not only the necessity for catheterization, but what could happen if there was a loss of bladder or bowel control, and to make sure that athletes are comfortable in this context. This is especially important for athletes with myelomeningeal seals because there is an increased risk of obesity in these athletes. So this might be one of their opportunities for improvement of not only athletic performance, but a means of exercise as well. There's also important to note that there's a high incidence of latex allergy in these patients, which means that you do have to be mindful when using things such as gloves. There's also a higher incidence of Chiari type 2 malformations and a higher risk of hydrocephalus. As such, we do want to be mindful of VP shunt injuries and to consider whether contact can be restricted or unrestricted in these athletes. The most important thing to consider is their actual safety, and as such, whether they can actually incorporate themselves into different athletic endeavors versus not others. For example, this is an example of Justin Gallegos, who is an energy drink athlete, and he was able to do a type of skateboarding that's modified. In addition to myelomeningeal seals, we also have athletes with cerebral palsy. As such, in these athletes, the flexors tend to be stronger than the extensors. So especially in the flexor compartment, it's important for us to be mindful of stretching in order to prevent injury. Cerebral palsy athletes are also very diverse in that approximately half of them are ambulatory and approximately half of them are wheelchair athletes. They also have a higher energy expenditure with movement. This includes the cost of breathing. As such, because of their um, because of an increased risk of decreased coordination, as well as more energy necessity, it's important to make sure that they're followed up with a nutritionist to make sure that they obtain their caloric intake correctly. In addition, there is an increased risk of ataxia and decreased coordination in these athletes, which emphasizes the importance of sport for them and their ability um, to actually do the sport. And this is an example of an athlete who actually he's the first Nike athlete with cerebral palsy to sign with Nike, and he was able to compete collegiately at Oregon as well. Differential athlete characteristics. So the first differential athlete characteristic that we're going to be discussing is the amputee athlete. So the amputee athlete can be either ambulatory or wheelchair bound, and as such is important to monitor that based off of what sport they're wanting to participate in. It's also important to pay attention to rules on prosthetic devices. So currently they're allowed in high schools in football, wrestling, soccer, and baseball, but they may not be allowed in all sports. For example, this is Jessica Long. She's an amputee swimmer, and prosthetics are not allowed in swimming. Um, it's also important to do skin exams for these patients because of an increased risk of prepatellar bursitis, overgrowth of the stump, as well as an increased risk of infection in these around the prosthetic in these patients. So it's important to be mindful of this. It's also important to be mindful, as previously mentioned, whether they're ambulatory or wheelchair bound. So in terms of specifically the wheelchair athlete, the most common injuries, as previously discussed and as seen through the National Wheelchair Association, were overuse injuries, especially of the shoulder and wrist. This is also seen within with an increased risk of carpal tunnel syndrome in these athletes, most likely due to their placement of their hands during competition. As well, in addition to the amputee athletes, it's also important for them to obtain proper skin exams, and this is due to a higher risk of pressure sores. So due to the increased amount of sitting all day, it's important to both have them move around as well as to then, when we're seeing them, to actually perform a skin exam to make sure that there are no pressure sores. Another type of athlete that we have is the athlete who's visually impaired. So the athlete who's visually impaired is defined as 2200 or greater with correction. So this may lead to a delay in motor skills depending on when the visual impairment actually started. And as such, it's important for the athlete to be accommodated as they gradually go, especially in the pediatric realm. There is a different amount of visual classifications of these athletes based off of the USABA, and as such, it's important to see what the athlete falls under in order to properly place them in the correct category for competition. In addition, we have hearing impairment or deafness. The most important factor um, for hearing impairment or deafness is the age of diagnosis. And it's important to obtain that within the actual history of the PPE. This is important because this increases or decreases their amount of verbalization, and as such, the amount of accommodation that might be necessary for this athlete. Um, Vestibular apparatus dysfunction can be accompanied with hearing impairment, and as such, it's important to monitor due to increased risk for decreased balance and to make sure that they're maintaining this. Hearing impaired athletes actually do have a type of competition called the Deaf Olympics, hosted by the USA Deaf Sport Federation, where hearing aids are not allowed. However, there are athletes who are competing in the NFL as well as other leagues who do have hearing impairment, and as such, they either use hearing aids or some of them use visual acuity as well. This is Matt Hamill. He is an UFC Olympic wrestler who actually is completely hearing impaired and as such doesn't use hearing aids, and he was able to compete both in the Deaf Olympics, and his main mechanism of communication was ASL. In terms of differentiating that, we also have intellectual disabilities in athletes. So according to DSM-4, this is defined as an IQ of 70 or less. And this does lead to a significant limitation in intellectual functioning and in adaptive behavior. Within these athletes, it's important to note that there is a risk of lower VO2 peak in these athletes. And as such, it's important to accommodate training with them. And they're also categorized under the Special Olympics flag. So it's important to also be mindful of the Special Olympics specific PPE for these athletes. In addition, there's the athletes with Down syndrome. So in these athletes, up to 15% of them might present with atlantoaxial instability, which can present as neck pain, torticollis. Previously, the Special Olympics did require lateral neck radiographs for every athlete with Down syndrome. And this was present in the article in 2010. However, there have been new guidelines since then, which only requires this, the lateral neck radiographs for high hyperextension or hyperreflection activities. And this includes diving, gymnastics, and soccer. Again, there's also a higher risk as in athletes with intellectual disability of lower VO2 peak or peak heart rates. And there is also a higher risk of congenital heart disease, upwards of 50% in these athletes. And it's important to be mindful of that when they're competing. As such, I do believe that this was a good article. However, there's more research needed, specifically on PPE for athletes with disability and the PPE as a whole, especially in terms of higher level research, moving up from level 5, potentially up to level 1. It's also important to see how exercise specifically affects athletes with disability, because most of these studies are based off of athletes without disability and correlation and computation to athletes with disabilities. It's also very important to increase physician training. So Holder et al. Did a 2009 study, and they found that 56% of medical school senior students felt inadequate in treating patients with disability, and only 61% of deans felt their students were competent enough to treat patients with disability. As such, it's important for us to both educate um, ourselves as well as future students about what dealing with an athlete with disabilities includes, as well as specifically guiding them as athletes. Thank you.
Awesome job, Matt. Before moderating the Q&A, I'd like to give Dr. Ng an opportunity to share any additional comments about the article.
Thank you. So Matthew, great work. I would say this was actually kind of a challenging article to do journal club on because it's not your typical format with, an intervention, a different group to compare with, and outcomes per se. It was a pretty dense article, so I like that Matthew did a really good job of just trying to condense it and make it easier to digest for people joining this journal club. There was one question that I wanted to ask you, Matthew. You had a slide about Down syndrome where you mentioned that athletes with Down syndrome tend to have lower VO2 max and lower peak heart rates. And so I was curious how this would affect the way that you would counsel athletes with Down syndrome, or perhaps their athletic trainers and coaches and whatnot.
Yeah, so I think that's a really important point to consider, especially when bringing up athletic trainers and coaches, is because we are part of a team, and as such, it's important for us to relay this information not only to athletes, but to the people who are actually with them every single day, both coaches as well as trainers and athletic trainers, who are with them every single day and are able to see them constantly performing. With this being said, I think it's important to note that athletes with Down syndrome can obtain a higher VO2 peak. And there was actually a study, I believe in 2007 by Balich et al., which actually showed that there was the potential for them to increase their VO2 peak as time went on. But it's also important to mention this guy on the screen, his name is Chris Nikic. He was the first man with Down syndrome to actually complete an Ironman. So it's important to note that they can do these things, but that we just need to be mindful of what is going on in each point with the athlete as they're training. Chris Nikich's idea behind training is 1% better, for example. And as such, we should push our athletes to try to be the best that they can, but be mindful of their limitations. So athletes with Down syndrome, because of a lower VO2 peak, may have different difficulty with thermoregulation, especially in hot environments. So that's an example of an idea to tell a coach, for example, maybe not training in the very middle of the day in hot Florida where I am, for example, maybe to be able to train early in the mornings to help with that thermoregulation.
So if there are no more questions,
I just said our comment real quick.
go ahead, please.
Hey, it is Dr. Troxler. Excellent presentation. And most of the sports in America, especially the Paralympic sports, a lot of the USA sports have taken over the Paralympics. So for track and field, which I'm involved in, we've taken over. There was a national association that regulated track and field. So with track and field, USA Track and Field starting January, which was pushed by the USOPC to start, officiating and controlling Paralympics with track and field. And we actually had our first meet this past weekend. We got many meets coming up. On the the autonomic dysfunction can be confusing, especially when it comes to board and even practicing. So in that problem, basically the parasympathetics have been knocked out with their spine injury, but they still have sympathetics. And so, we check those athletes at the starting line and, they're warmed up. So their heart rate is up, maybe 110. The ones that are boosting, of course, their heart rate's up to 190. And really, there's no other way to check for them. And the article kind of mentioned that it's more of a clinical evaluation. There's no drug tests. So you just got to check them at the starting line. And the boards, they typically like to confuse you because they'll present a patient with a C5 injury, a T5 injury, which is above T6. And usually it's a gunshot wound, but since this is sports medicine, it's usually some penetrating injury like a javelin gets stuck in their back and they're bleeding everywhere. And of course, their blood pressure is low, so they're hypotensive, but they're bradycardic. And they ask you on the boards, what's the next step? And giving blood is one of them. But it's not a hemorrhagic shock. It's from neurogenic shock, which is the opposite of the autonomic reflexia. So their sympathetics are knocked out, so they're bradycardic. And so the boards and really in practice likes to mix those two together. This article didn't mention neurogenic shock or spinal shock, but anybody that works in the ER like myself, we face this regularly. Overall, great article. I really like this article, especially if, like myself, who take care of para athletes. It's very concise and very lengthy. Very good article for anybody who's going to work with para athletes. Thanks.
Just waiting a few more seconds to see if there's any more comments.
And Dr. Troxler, I was actually curious. You mentioned that it can be pretty difficult to identify athletes who are boosting when you're comparing them with athletes who have been warmed up. So I was wondering if you have a heart rate threshold that you use to help you determine whether they've been boosting or not.
And that's the hard part. There's no specific guidelines. And even though, and I went to the WADA meeting last year in France, and we talked about this, boosting is not actually on the prohibited list. And so I guess unofficially it's they haven't really addressed it yet. But, if you have 8 athletes in the finals and 7 have a heart rate of 120 and 1 has a heart rate of 190, you probably should check their Foley and check how tightly their legs are bound. And so make sure they're not boosting. But there's not a checklist you can go through, and that's what makes it so difficult. And that's why a lot of the para athletes are unhappy, because it's not on the prohibited list. And WADA hasn't really taken enough steps to prevent this from happening, but it's been addressed, and I imagine we'll probably see something in the near future.
Thank you.
There are no more questions or comments. So I want to thank Matt for his outstanding presentation. I also like to thank Dr. Ng for serving as the club mentor, and I also like to thank everyone for attending tonight's AMSSM Journal Club meeting. I'm pleased to announce that we have one more AMSSM Journal Club meeting in May that will be held on Tuesday, May 20th at 8 p.m. Eastern Standard Time, where we're going to feature 2 presentations, and I hope everyone can join for that. This concludes tonight's meeting, and just thank you, everyone.